Women comprise 51% of Uganda's entire population. 45.4% account for those above the age of 18. Over 87% of women live in the rural areas. For most of these women, access to quality reproductive health services is inadequate and in some cases non-existent. As a result, most women in rural communities live with and suffer from reproductive health-related diseases that would otherwise have been prevented or treated if they had been detected in the early stages. Even in urban areas where health facilities are relatively accessible, many women only consult when reproductive-related issues such as antenatal arise. This is Ward 5B at Mulago Hospital. The patients here are middle-aged women suffering from advanced and severe stages of cervical cancer, believed to be the leading cause of death in women who are not pregnant. Over 65% of the beds in female wards are occupied by these hopeless and unfortunate cases. If these women had been diagnosed early enough, the story would have been different. Globally, cervical cancer causes over 270,000 deaths each year, and 500,000 new cases occur, of which 85% are in the developing countries. Dr. Pius Okong is a senior consultant obstetrician gynecologist at Nsambya Hospital. He has diagnosed and treated a number of cervical cancer patients in his 27-year career. But what is cervical cancer and what causes it?
It's a fairly common cancer. It occurs in a hidden part of the womb, which projects into the birth canal. And in medical terminology, sometimes they call that the cervix. But it's just part of the womb which projects into the birth canal. We know for certain that a person who has been sexually active may acquire an infection by a very small organism called a virus. And that virus may cause an infection. Usually the one which is easy to see is called in Uganda ensundo. And that's a wart. It grows on the genital parts on the outside. The one which can lead to abnormalities due to eventually to cancer does not cause such growth. So it's called human papillomavirus. It's a small particle, very, very small, and it's sexually transmitted. So a person who has never had sexual intercourse at all will not acquire that virus. But somebody who has had sexual intercourse will acquire that virus. And then the virus will cause changes over the covering, the lining of the neck of the womb, or that part of the womb which projects into the birth canal. Now these changes can take 10 to 20 years to show themselves up. So it's a very slow process. The majority of people who acquire this infection, they will eliminate the infection without any problem. But there are few people, maybe 5-10%, it will persist. It will keep coming back, it will keep coming back, and those are the ones that may progress onto cancer.
Indeed, because of slow manifestation of early signs and symptoms, and the fact that the victims do not initially feel pain, the infection progresses unnoticed.
The cancer of the cervix has what we call pre-cancer or some signs. They are not symptoms, mark you. The symptoms are what a patient would feel. But the signs is what we see as health workers. So it has that long period of time where it may warn you if someone examines you that one day you could develop cancer. And this could take from 10 to 15 years. And if you treat that person won't develop cancer. But she needs to have availed herself to a health worker for an examination so that the person says, no, one day you will develop cancer because you have this condition that looks like you will develop cancer. Now, the cancer itself begins off early, and the earliest symptoms are bleeding after sexual intercourse. And the bleeding could be very tiny, a drop. There is no pain. And it may take 2 years. You get it, sometimes you don't get it, you have no pain. So the women again, because it is bleeding from the birth canal, tend to keep quiet about that. And it's a drop. So she says, after all, it is a drop, I have no pain. Then as the disease advances, you start bleeding irregularly. You may bleed for a long time. She may seem to bleed like a period, and then it continues. And then in the very advanced stages where they have infection, then they start getting this foul discharge.
A normal cervix has got a front part and a back part, and should not have any areas which are unusually red. When it becomes abnormal and it's visible, then it will change. And usually then some red areas may appear or some lumpy areas. The next stage of abnormality, that red area may actually grow, and that may indicate that there is cancer there. And that area is usually limited only to one area like that. And when this area is rubbed or touched, for example, when a woman is washing herself and she touches that area, it will bleed. When she's having sexual intercourse, because the man may reach this area here, that area will again bleed. Because this area is also very close to the intestine at the back. When the woman is passing stool, it can rub against this part, again she'll bleed. As the abnormality grows, sometimes it grows outwards like that and looks like a little pimple or even a much bigger one. And then bleeding can occur all the time, even without provocation. And sometimes then it begins to spread to other parts of the neck of the womb or the cervix. And as it continues spreading, eventually the normal appearance of the neck of the womb disappears. And it's this spread which continues not only on the cervix, but inwards to the womb itself, in front to the bladder, and the back to the rectum where the stool passes.
The burden of cervical cancer is huge, yet many women are unaware that they are at risk or are actually affected. The long period of no early symptoms and the confusion of the subsequent advanced symptoms with those of other gynecological diseases create a challenge for early diagnosis.
The biggest problem, as far as I can see, is mistaking the symptoms to be something else. For example, a woman can bleed between her periods, and she just thinks, well, my period has come too early. So the complication there, they delay to seek care.
Women with the disease in its late stages experience a lot of suffering and neglect.
When they come now and find this cancer has spread, and then it has spread into where the urine collects, and the urine starts leaking by itself. It has spread where normally the stool will collect in the large intestine, and then the stool will start leaking by itself. Or it presses in that area, the woman is unable to pass stool completely. If it spreads to the area where the urine drains from, it can also block the urine draining. Then there is kidney damage. If it spreads much further than that, it may reach the nerves going to the legs, the back. Then they get a lot of pain in the legs, pain in the back. It can also obstruct or stop blood flowing properly from the lower part of the body to the upper part, and then eventually the legs will swell.
58-year-old Imelda Naluyinda has 3 children. She got married at the age of 17 and had her first pregnancy at the same age. She started seeing symptoms in her 40s. For close to 18 years, Imelda experienced all signs of advanced cervical cancer but never got proper diagnosis. At 52, Nabanja Fatuma is a mother of 9. She got married at the age of 16 and had her first child then. Fatuma started seeing signs of advanced cancer at the age of 51, and even then she assumed it was some gynecological related problem.
Kakati natandika okusiyibwa mu kifo ekyekyama ne baŋŋamba nti obubaka bw'otongo ekyavaamu ne nfuna amazzi amatonotono ddala ne nzijjako mu ddwaliro wano olw'obutaasobola kufuna laba layini etambuza bulwadde obwo ne bannimba mpeke eri mu ddwaliro ery'ekyengulu ekkadde. Ngenda mu famasi ne ngula empeke nnyingi nnyo zitwala ssente nnyingi nnyo. Agenda okulaba nga sikiwukako. Kyava ekyo obulwadde ne butandika kweyongera.
The ladies that come to us with the cervical cancer tend to come too late for us to do anything to help them. The problem tends to be that they probably do not know how it presents, so they wait until the symptoms have become very big, very massive, and they've tried. Because they try here and there, the traditional, the nearby clinics, before they even actually come to somebody who knows how to diagnose cervical cancer.
Cervical cancer is almost the only cancer in women that can be prevented with effective screening and treatment programs. However, absence of effective sensitization and inaccessibility to screening and treatment facilities exacerbates the problem.
Even if you make a diagnosis and you say you have a precancer lesion or you have an early cancer, expecting a woman to walk from a beam maybe to the nearest referral, which is Soroti, or from say Bundibujo to Fort Portal, or from wherever they are, to travel a long distance for a condition which in its early stages doesn't have any symptoms, is expecting them too much when they have so many other needs that compete with their money.
To be truly effective, cervical cancer prevention programs need to be linked to appropriate treatment, including outpatient procedures. But what is the possibility of attaining this capacity?
The prevention needs training from the primary person, health worker who sees the woman, should be able to screen the women, refer them. Now the problem comes as to where you're going to refer these women to. Because they should, if they have an abnormal test, should see a gynecologist who should be able to treat them.
This is a health education session being conducted by health workers at Kampala City Council Clinic, Naguru. During the session, the women are sensitized and given information about both cervical and breast cancers. They are also prepared to undergo the cervical cancer test. This clinic is one of the 2 specialized screening clinics for breast and cervical cancers in Kampala under the Uganda Women's Health Initiative project.
After they have had the health education and they have consented to participate in the screening exercise, they come into this room. We take her through step by step what we are going to do.
In these clinics, the health workers use simple and affordable technology to carry out the cervical cancer screening tests.
When we want to see that part of the womb, we pass this instrument in like that, and we open it, and then we can see the neck of the womb. This instrument alone, together with vinegar, which is sold in the supermarkets, can be used by a nurse or a midwife in a health center 2 or even health center 3, and apply the vinegar into the birth canal, apply it on the neck of the womb. A normal cervix will remain pink like this without any problem. A cervix which has got abnormalities before cancer will show white areas, and so a nurse or a midwife will be able to send that patient or that mother to where there's a doctor who can do other investigations. So this is the simplest screening test for cancer of the cervix.
Once these signs are identified, the patients are taken to a higher level facility where they can receive treatment using cryotherapy. The system comprises a nitrous oxide gas cylinder and a cryo machine.
The compressed nitrous oxide gas goes through this tube at a very high pressure, and when it impinges on the probe here, it's able to freeze it to a temperature of minus 80 degrees. And we apply this frozen tip onto the cervix for a period of 3 minutes, and then it thaws for another 3 minutes, and then we refreeze again for 3 minutes. And we're able to destroy all the cells that are abnormal on the cervix.
The system does not require electricity and is effective where doctors, health supplies and health infrastructure are limited.
For this clinic, we are offering the service free of charge because we are trying to demonstrate that you can integrate it within existing health systems of the government. But we are getting funding from University College London in the UK to be able to pay for the logistics, the equipment and the staff to run this program.
Towards the end of 2006, the Ministry of Health launched a cervical screening project supported by World Health Organization, initially focusing on Masaka. Subsequently, the project has been scaled up to include 6 neighboring districts using Masaka Hospital Regional Referral Hospital System.
This hospital caters for about 6 districts. There is Rakai districts, there is Lyantonde, there is Sembabule, there is Kalangala, and also Masaka district, and of course other different parts like Mpigi, Mityana, and even part of Mbarara, and even Tanzania. We have all the screening facilities, treatment for precancerous lesions. We are able to make a definitive diagnosis, and we are also able to operate those patients who have early disease in which we can achieve a cure. The only facility we don't have here is radiotherapy.
34-year-old Nabanova Mulindwa lives in Bukulula, Kalungu, Masaka district. She had her first screening at Bukulula Health Center a month ago, and she's happy with the experience.
Nzirayo.
1 year down the road, the project has challenges.
We have only 2 guns, cryotherapy guns, for the entire 5 regions currently. And that is a major problem. These ladies come from much further than even the health centers. Usually they have to walk 5 miles, 2 miles. And so when they come and you identify the disease, then you refer them again to Masaka, which is also now some distance away. A good number of them are unlikely to reach here. Another problem is, of course, those whom we identify with disease. As I told you, most of them have advanced disease. And with advanced disease, there is no option apart from radiotherapy. Some of these people have never gone beyond their home areas. So going to a new place as far as Mulago, last year we referred about 30 patients. But of those, about only 30% were able to do what? To reach Mulago. Most of them actually do not go, and they stay in the village. They are unable to go. They come back to us, and we just manage them palliatively here.
Pap smear is another cervical cancer screening method. Although the pap smear screening programs have been available since the 1950s, they have not taken root in resource-poor countries.
One, mainly because it is labor-intensive. It requires highly skilled people, including cytotechnicians and pathologists. It also requires what I would call high-tech labs.
Government, through the Ministry of Health, is aware of the bottlenecks involved in setting up an effective cervical cancer control program and has drawn up a strategic plan to address them.
The policy is very clear. The health sector strategic plan, our national reproductive health policy, cater for cancer of the cervix. And the national strategic plan is to operationalize the existing policy.
Building capacity for health researchers and health service providers is very vital in the fight against cervical cancer. As part of their training, trainees at Mulago Nursing School are taught how to carry out cervical cancer screening. Despite putting out so many health workers, their impact needs support in terms of infrastructure facilities and focused programs to be felt. During its 88 years of training doctors, Makerere University Medical School has always and continues to take the subject of cervical cancer very seriously.
We've been training mainly medical doctors over these years, and during the course of their training, both at undergraduate and postgraduate, cervical cancer is a disease that really features highly because this is the commonest cancer among women in this country. And therefore the undergraduates are introduced and exposed to this disease and taught how to diagnose it, how to prevent it, and also how to care for the patients who show up with this particular disease.
Advanced cervical cancer requires a lot of resources to treat and follow up, and the prognosis is not satisfactory. These women have been diagnosed with advanced severe cancer. Some of them are waiting for radiotherapy treatment, while others are already on the treatment. By the time these women get a correct diagnosis, most will have spent between 2 and 10 weeks because the facilities are inadequate.
The number is too big, and sometimes we take long to do what? To work on them because of their big number.
This is the radiotherapy department at Mulago Hospital. The facility here is meant to serve the entire country in as far as radiotherapy treatment is concerned. The recommended standard is 1 radiotherapy machine per 3 million people. Therefore, Uganda would need about 10 of these to adequately serve its population. The 12-year-old radiotherapy cobalt machine is the only one in the country. No doubt, the facility is overwhelmed by the workload.
It's getting old. The breakdowns are frequent, and although we are able to repair them within 2 to 3 days, that interruption in treatment has a very big effect on the outcome. If you have to treat cancer of the cervix properly, the whole course of treatment has to end within about 7 weeks. But the treatment itself on the big machine takes about 5 weeks. So you can see that we are working under a lot of stress with a lot of patients, and we are not able to put them through the proper treatment as required, just because there are too many and we have just one equipment of each type.
Makerere University Medical School, Department of Pathology at Mulago. Another important facility in their diagnosis of cancer. It is the only accredited cancer laboratory and the prime national cancer registry. The statistics of the cervical cancer cases here are worrying. This disease accounts for over 40% of all cancers recorded in this registry, and trend data indicates that this has been increasing over the years. It is the most common reproductive tract cancer in women, accounting for over 80% of cases.
If we look at the women tissues, we receive about 5,000 tissues, the whole country. Out of those, half are infections and so on. The other half are cancers. Out of those 2,500, about 1,000 are cancer of the cervix.
Many women who had advanced cervical cancer have undergone treatment that has enabled them to have a new lease of life. 51-year-old Peace Amanyire lives in Rubaga, a Kampala suburb. A mother of 7, Amanyire got married at the age of 20. At 48, she started getting signs of cancer, but thought it was some gynecological-related condition.
Well, I told a friend that I have a problem with the bladder, and she was like, no, that one normally comes with age and, pushing many children, but there is a way you can start tying the bladder when you are sitting. That exercise can stop the urine from coming. And I did it for like a year, but nothing changed.
For 3 years, Amanyire lived with the unpleasant discharge until she took a decision to consult a doctor.
So when she examined me, she was shocked. The only question she asked me that time was, "You look someone understanding. Where have you been all this time?" But me, I was innocent. What's wrong with me? Am I sick? So when she realized that I was innocent, the day after that, she took me to theater and operated me.
The 5-hour major operation, which was done at Rubaga Hospital, was successful, although it was a complicated one.
She removed the uterus, the cervix was bad, and the disease had almost penetrated the bladder and the rectum, and she had difficulty during the operation.
After recovery, Amanyire decided to focus on living positively. Today, she's involved in a voluntary cervical cancer awareness campaign to sensitize women about the dangers of the disease.
I don't focus on cancer. I don't want to live, worrying all the time, I have cancer. That's why I decided to come up and, try to speak, to sensitize other women, not to go through what I went through.
In the absence of cure for many virus-transmitted diseases, vaccines remain the only preventive measures against infections. Scientists have developed HPV vaccines that have been tested and proven to be safe and effective. It has been licensed in many countries, including Uganda, and is due for introduction.
The vaccine is very effective. We are only looking at the modalities of introducing it. And we think once we introduce it among the young girls, we think we can address it, because in future these are the girls who get affected by the cancer of the cervix.
Program for Appropriate Technology in Health, PATH, an international organization whose mission is to strengthen health systems in the world, has come in to study the methods of delivering this vaccine using the existing health systems.
PATH comes in to actually working with government to deliver this vaccine and then study those kinds of methods that are actually, at the end of it all, cost-effective, feasible, to delivering this vaccine. So that's why we think before the vaccine is actually introduced widely, we should really understand the systems through which it can actually go and really see what needs to be improved. So at the end of the project, we shall have all this data. If you use strategy A, it will be cost-effective, If you use strategy B, maybe it may be less cost-effective, and that will be weighed against also other kind of possible interventions like screening. So at the end of the day, the government will be able to decide whether they may want to introduce the vaccine or they may want to introduce screening services.
The Ministry of Health is in agreement with the proposal and is in the final preparation to implement it.
We are a long way in introducing it, but first is to get the needs assessment, make sure that we have data, especially community perceptions among parents, among the children, because we are going to start with the school-going children.
Working in partnership with PATH, WHO endorses and fully supports the program.
There is no doubt about this. the efficacy of this vaccine, and that the fact that we are working with PATH to put it into operation shows that we fully believe in this one. We fully see the benefits of this program.
In 2007, PATH, in partnership with Macquarie University's Child Health Development Center, a multidisciplinary research center, and the Association of Obstetricians and Gynecologists of Uganda, carried out research to assess the readiness of the health system to introduce the human papillomavirus vaccine. The research covered 5 districts of Mbarara, Kampala, Gulu, Soroti, and Masaka.
The formative research was only the first step, in the sense that the data that we generated from this research is now being used to, one, try out different options. There is a project that PATH is continuing with them in collaboration with the UNEP and Ministry of Health to see what's the best delivery strategy for delivering this kind of vaccine to young girls, for example, and looking at is it feasible, and is it issues of acceptability. So I think there's still a second phase of this research that hasn't yet, that will generate more data. And then at the end of it, the government would be in a position, I think, to make a decision as to whether they would like to introduce the HPV vaccine in this country or not.
Cervical cancer is no doubt a heavy burden, not only for Uganda, but the entire developing world. Total control of this silent killer will need concerted effort and commitment of all the stakeholders, but most importantly, instituting an appropriate sensitization program to educate women about it.